Thank you, everyone. Thank you, everyone, for joining us tonight. So as Carter said, my name is Cindy Roper. I'm a palliative care physician, and I'm really glad that the division has given us the opportunity to share with you today, as well as with my fellow palliative care colleagues. We want to share with you today some information that we think may be helpful to you should you be facing end of life, or help you to support your loved ones as you are journeying with them. What we've decided to share today in this presentation comes from common questions that we've encountered when taking care of our patients. So today, as I will be going through these topics with you, I will be using the story of a fictional patient named Heather and her husband, Tom, as they face Heather's new diagnosis of end-stage cancer. After the presentation, our speakers from various areas of palliative care will share with you their experiences and answer some questions you have. So I feel very fortunate today to have representation on the panel from many different areas of palliative care. So I want to thank my colleagues, Dr. Kevin Slater, Ms. Bella Wang, Dr. Joan Eddy, as well as Dr. Anu Tamber. Also, we have a special guest today, Ms. Shauna Lim, who will be sharing her experience of walking with her father at end of life. And special thanks to Ms. Lisa Laflamme and Dr. Julie Ridley, who I don't think can make it today, but have contributed to this presentation. So just disclosure in the beginning, we don't have any affiliations with any profit or nonprofit organizations. Now, before we start, I just want to say that palliative care is a very broad umbrella topic. It includes providing care for patients with many types of diseases and early on in their disease trajectory. However, for the purpose of this presentation, we are focusing on a patient with cancer who is in their last year of life. There are many topics that are very important and relevant to end of life, but we can't cover all of it today. You may notice that we are not going to spend very much time on advanced care planning, which is really a topic on its own. So if there's anything else you want to be covered with more depth, definitely give the division and Carter that feedback so we can consider that for future presentation. And also keep in mind that today we might be talking about specific palliative care services, and that might come up in the discussion, but the criteria and referral process for these change with time and differ from location to location of care. So if you have any specific questions about services, please touch base with your local health authority and community services. So some of the things we want to talk about today with the story of Heather and Tom. What is palliative care? Who receives palliative care? Where can I receive palliative care and who provides it? Will I have uncontrolled pain at end of life? What kind of side effects will I have to the medication? How much time do I have left? And what does palliative care at home look like? Now, going back to our presentation, Heather, to our story, Heather is a 60-year-old elementary school teacher. She's married to Tom of 30 years, and they have a daughter, Jenny. 2 months ago, she was diagnosed with liver cancer, which unfortunately spread to other areas of her body. The cancer is not curable. She and her oncologist have decided to start cancer therapy that will give her more time, but cannot cure the cancer. And though Heather and Tom are fictional, they just remind me so much of many of the patients that myself and my colleagues have met. Since her diagnosis, Heather and Tom feels that their world has turned upside down. They had looked forward to their retirement life together and all the traveling that they were to do. The future seems dark and uncertain. Does this sound familiar to you? Does this sound like someone that you maybe a loved one or a friend that had walked through this journey? I think it's a very common story. So Heather has been experiencing pain in her stomach, insomnia, and increased anxiety. At her appointment today, her oncologist recommended a referral to the palliative care team. Heather is surprised. Though she has cancer, she can still take care of herself and her home. She wonders, does this mean I'm imminently dying and that cancer therapy has to be stopped? Has my doctor given up on me? I had a friend who died in hospice a few years ago. Is palliative care the same as hospice? Heather may be thinking all of these questions, but feel too overwhelmed to ask. Often it can be pretty overwhelming to be at the doctor's office, especially if you're receiving bad news, when you're hearing that your medical condition is changing. You might not even be able to organize your thoughts. It's okay to take the time to process, to write down your questions, talk to your family, and then ask the questions in a follow-up appointment. Now, what is palliative care? So this is a very common question that people have when first introduced to palliative care. What is it? And I think that there could be a lot of misconceptions of palliative care, and people often do not realize the broad scope of this field. It's important to know that palliative care is not a location. It's an approach to care. It aims to improve the quality of life of patients and their families with life-limiting illness. This can be cancer, heart failure, chronic obstructive pulmonary disease, neurodegenerative disease, such as dementia. So palliative care is holistic whole person care. It involves the physical, the mental, emotional, the spiritual. Physical could be issues about your body, about how it feels to breathe, to move. Emotions could be about how you're feeling, feelings of gratitude, feelings of hope, feeling like crying. The spiritual aspects refers to what people may call the soul, connecting with others, your purpose in life, connecting with a higher power, expressing yourself through music or art or writing. And the mental aspects involves your mind, thinking, your intellect. Ultimately, in palliative care, we hope to treat the whole person and to see the person as an individual and not just a disease. One of the most common misconceptions I think that people have is that palliative care is comfort care, which is just for the very last days or weeks of life, that only aggressive medical care is needed at the beginning. And when that's no longer helpful, the patient is transitioned to hospice. And that's an incorrect conception. So palliative care should be started early and can happen together with active disease treatments. This diagram illustrates this model. So what we see here is two interlocking triangles. You have the blue triangle representing active disease management. So this could be surgery, chemotherapy. For cancer, it could be placement of a pacemaker, defibrillator for someone with heart problems. The pink triangle on the right represents palliative treatments. This would be managing symptoms like pain, fatigue, nausea, anxiety, depression. So rather than starting these palliative management at the very end of life, they should be started early when all active medical management may be taking place. These treatments help a patient feel better and improves their quality of life. And over time, if you look at the blue arrow at the bottom, as the disease progresses, we gradually move on to have more palliative care. So this transition from active disease management, potentially very aggressive medical care, to palliative care is a gradual one, and both can happen together. They're not mutually exclusive. Now, where can you receive palliative care? You can receive palliative care regardless of where you are. This could be at the hospital. This could be at the clinic, your family physician's clinics, or the BC Cancer Pain and Symptom Management Clinic. It could be at home and community. It could be at hospice. And who provides palliative care? Palliative care is a specialty that involves many disciplines. And during the course of patient's illness, the palliative care can be provided by your family doctor, your cancer doctor, your hospital doctor, home health nursing, your palliative nurse, social worker, counselor, spiritual care provider, a specialist palliative care doctor, or your specialist in neurology or cardiology. Going back to the story of Heather, her oncologist reassures her that her cancer treatment will continue along with palliative care treatment. She tells Heather that palliative care can improve her symptoms and quality of life so she can make the most of the time she has with her family. In this case, Heather's introduction to palliative care started with her oncologist, who identifies her as needing palliative care and makes a referral to the team. But I also want to note there's many different starting points from which palliative care can start. Often it starts with a patient's family doctor, who identifies a need, starts initial treatment, and refers for specialist support if needed. So the following week, Heather meets the cancer clinic palliative care team. The palliative care doctor there explains to her that he will be working with her family doctor to address her symptoms. After initial exam, he recommends starting some medication for abdominal pain. So before we start talking about the pain medications, which is our next section, I do want to pose a question to one of our panelists, Dr. Tamber, and she is one of the palliative care physicians at our at the Surrey Fraser Valley Cancer Agency Pain and Symptom Management Clinic. So I just want to see, Dr. Tamber, whether you have anything that you feel like patients should know about the clinic and the type of service it provides.
Thanks, Dr. Roper. It's a pleasure talking to everyone. I think actually Dr. Roper did a really good job of describing some of the patients that we see in the cancer agency. So one of the things that I would highlight about the pain and symptom clinic at BC Cancer is that when we think about that bow tie model, we actually see a whole spectrum of patients in our clinic. Sometimes we see patients when they've just first been diagnosed, and they might be experiencing pain from their tumor. And as they receive treatment, that pain goes away and they no longer need to see us. Sometimes we see people who actually have been cured of their cancer, but they're having pain as a result of the treatment that they received. For example, they might have pain in their hands and feet because of the chemotherapy that they received for their cancer. So they may no longer have cancer, but we still want to improve their quality of life. When patients are doing well and when their pain needs or their symptom needs are stable, we work really closely with their family doctors. And so sometimes patients will go back and forth between the cancer clinic and their family doctor or their medical oncologist. So once they're stabilized in our clinic, we'll return them to the care of their family doctor, and they may be with their family doctor looking after their palliative care needs for many months. And if something is going on that requires our assistance, our specialized care again, they get referred back to us.
Thank you very much, Dr. Tamber. I also want to pose a question for Dr. Slater. Now, Dr. Slater is a family physician in the Tri-Cities community, but he's also a palliative care physician. So Dr. Slater, I just want to ask you, how would you explain to a patient about how the family physician and the palliative physician will work together in providing care for a patient and their family at end of life?
Sure. Thank you, Cindy, for the question. So family physicians have the longer relationship with patients generally. So, and often, the initial diagnosis of disease and initial management is, of course, planned and orchestrated by the family physician. And then once a patient is referred to other experts, consultants, palliative care, and others, the family physician remains the quarterback for managing conditions related to that disease process, but then also managing some of the other non-palliative, conditions. So other medical conditions that may still require treatment and monitoring, prescriptions for diabetes and high blood pressure and things like that. As Dr. Tamber mentioned, there may be windows of time where the family physician is managing most elements of the disease, but then sharing care with the community or hospital or symptom management physicians, kind of a shared care model essentially, where all the physicians are taking part in managing best care, but the family physician hopefully kind of keeps everything from falling, looking after all of those in between things, keeping track of all of the other aspects of a patient's care that may not be specifically the palliative disease focused parts of the problem.
Thank you, Kevin. That was really well said. I think often the family physician remains, if I can use a football analogy, the quarterback of the whole situation, and working with the palliative care team, but also continue to manage all of the other aspects of the patient's health, because those things need to continue even if a patient has a new diagnosis of a life-limiting illness. Thank you very much. So now Heather's palliative care physician talks to her about starting some patients for pain. So Heather has the following concerns. What are the side effects of these medications? Will I just be drowsy from the medications and be tired all the time? Will I become addicted? Will I have uncontrolled pain as my disease progresses? Heather, up to this point, has been a healthy woman and has not had to take any medications other than a vitamin. So to her, it's quite daunting to have to start a new medication. So some common symptoms and concerns managed in palliative care. The four most common ones would often be pain, nausea and vomiting, shortness of breath, as well as confusion. And these can often be effectively treated. Other symptoms include dry mouth, itchiness, dizziness, tiredness, bleeding, bowel, and bladder issues, and these are managed as well. Strong opioids, such as morphine and hydromorphone, are often required for cancer pain. If a patient is having pain from cancer, Advil and Tylenol often are inadequate to control their pain. So in terms of how we decide on the doses could be different depending on the person. Our approach is to start at a low dose and to slowly adjust it based on the patient's need to avoid and minimize side effects. Often other non-opioid medications would be used to help complement the morphine or the hydromorphone. Non-medications may be used as well, such as radiation therapy to shrink tumor to reduce pain. Anxiety and depression can also contribute and worsen pain, and this needs to be managed as well. Most cancer pain can be controlled with strong opioids following appropriate palliative care guidelines. Some studies actually show that over 70% of patients can obtain good relief, and almost 90% can achieve pain control that is at least satisfactory. So in the majority of cases, pain can be well controlled for patients in palliative care with appropriate treatment. So what are the side effects? Very good question. So nausea is a common side effect for morphine and hydromorphone. However, it often resolves after the patient has been on an opioid for short weeks, sometimes 1 or 2. Some people may not have nausea at all. But if nausea is an issue, we will often initiate an anti-nausea medication regularly until this nausea resolves. In some cases, it may be continued for some patients. Now, constipation, unfortunately, remains a side effect, and that will continue as long as the opioid is continued. So we often joke that the hand that writes the prescription for the opioid also needs to write the prescription for the laxative. And again, with the laxative, this could be well managed. Drowsiness. Some patients may initially feel tired when they start an opioid, but tolerance to a dose typically develops in a few days, and the drowsiness should reduce or subside completely. Neurological side effects, such as twitching or confusion, may represent toxicity of the medication, and this is very rare, and prescribers do monitor closely for it. So what's important to note is that, yes, there are side effects, but most side effects can be very effectively managed and mitigated. So some of the common fears that we see are listed here, and many people are understandably worried or even fearful of these medications. They are powerful drugs, and when abused, they could be very harmful and even dangerous. And this is where we hear on the news about people abusing opioids and overdosing. However, it's a completely different scenario when opioid is used appropriately and carefully as a medicine with monitoring by the medical team. So people are often worried about addiction, and this is very rare when used for cancer pain management and can be screened for. We can screen for patients who are more at risk for it. People are worried that if they use the medication now, it won't be effective when their pain becomes worse. The dose can be adjusted, and there is no ceiling effect with strong opioids, meaning that we can continue to adjust the dose if the pain worsens. People are worried that opioids will just make you feel, quote unquote, doped up and less aware. But good pain control improves patient function and quality of life. And drowsiness subsides after a stable dose is established. And many people feel that they can do much more when their pain is well controlled. Some people are afraid because they feel that they are allergic, they've had a bad response before. And this is important to tease out. And your doctor may be asking you some specific questions about the reactions you have had, because sometimes these bad effects may have been due to inappropriate dosing, the dosing was too high for you, or that the side effects weren't effectively managed and were mistaken for an allergy. So going back to Heather, the palliative care physician reassures Heather that with careful assessment and adjustment of her medication, her pain can be controlled. They also make a plan to manage her side effects. The palliative team is quite concerned about her feelings of sadness and anxiety, so they refer her to see a counselor. They also invite her husband, Tom, to join. So when a patient is diagnosed with end-stage cancer like Heather is, the physical changes and symptoms may be easier to see and identify, but the emotional and spiritual needs can also take a very heavy toll. Illness often triggers a sense of hopelessness and loss of meaning for patients. It's often that patients feel that there's a lot of uncertainty in their lives, and anxiety is very common and natural in these situations. A person facing an incurable illness is challenged to develop meaning and discover hope in the remaining days of their life. Heather and Tom meets with their counselor. Heather tells the counselor that she fears being a burden to Tom. She's used to being the caregiver in her family. What would it be like to be taken care of instead? Tom confides that when he is alone, he's often crying and thinking about Heather dying. Throughout their marriage, Heather has been his main source of support and friendship. It's important for loved ones and healthcare providers to realize that the emotional and spiritual suffering is very common when patients are facing a life-limiting illness. And we need to acknowledge the suffering and provide support early on. So I do have some resources listed at the end of the presentation, and some of the support can come from your own social network, such as your friends, family, faith community, independent counselor, psychologist, perhaps through your work and medical plan. The BC Cancer Agency also has psychiatrists and counselors to support patient and family, hospital social workers, palliative care team social worker, as well as your family doctor is a very key resource. Several weeks pass and Heather begins feeling better with the initiation of her pain management plan. Reducing her pain helps her to better enjoy her day. Her sleep and anxiety has also improved. She hopes that the cancer therapy will be effective so she can have as much time as possible with her family. Now that brings us to another question. How much more time? How long have I got? This is an important question. It's one that most people facing end of life will think about and eventually ask. But answering the question as fully as possible reflects both the science and the art of providing care. So Heather knows that her cancer can't be cured. A few months ago, she was told that the average survival of patients with the same diagnosis is less than a year. She's been feeling weaker and she wonders how much more time she has to live. She wants to hope for the best, but also wants to prepare her family and herself. Not everyone wants to know how much time they have to live with their illness. Sometimes the loved ones may have different wishes from the patients. Patients have the right to know this information if they want it. And the patient have the right not to know this information and can decide whether their loved ones are told their prognosis or not. Now, what is a prognosis? A prognosis is a prediction about the course a disease will take for a particular person. It's never exact. The type of disease, the treatments available and chosen, the patient's other medical conditions, and how they are overall will impact the prognosis. Some disease progress in a very predictable way, while others can be very unpredictable. We often feel that certain cancers progress in a more predictable trajectory, whereas non-cancers such as congestive heart failure or lung disease can have a more unpredictable course. Prognosis can also include information on how things might change for patients. So it's not just about time. It includes problems that might happen, such as infection or bleeding, and changes in how much a person can do for themselves, such as needing help with walking, dressing, eating. Your doctor may describe prognosis to you in a timeline, usually in a range, weeks to months, less than 6 months, or between 3 to 6 months. Information about prognosis early on usually come from large studies, and this is the best source of information. But as the disease progresses and we're getting more to the end stage of the disease, what is most informative is often how a patient changes over time. This may be in their ability to work, look after themselves, how much time they spend in bed. So we look at how much a patient is changing over time, as well as how that momentum of change, how quickly they're changing. And that often gives us a good sense of how much time may be left. Prognosis usually becomes more accurate as patient approaches end of life, and the doctors become better at predicting as we're getting closer to the end. So we try our best to give a time range for prognosis, but do remember that prognosis can change as a disease progresses. It can be longer or shorter than expected. Sudden events such as a blood clot or an infection can cause end of life to come much faster than expected originally. So do be prepared for surprises and consider asking for a best and worst case scenario when talking to your doctor. So Heather and Tom, they discuss with their family doctor where she is currently in her medical condition and how things may change in the coming weeks and months. They discuss her goals of care and what is important to her in her care plan. They document these goals together and plan to regularly follow up as her healthcare continues to change. So due to limited time, we're not able to go into depth today regarding advanced care planning. Advanced care planning and goals of care discussion involves you, your loved ones, and your healthcare team. It involves discussing your illness, what your values are, and what treatments may still be helpful to you. And as your disease changes, your goals and what is helpful may change too. So I won't be able to go into depth on this topic today, but what I do want to emphasize is that goals of care discussions are very nuanced. It's not just about whether or not you want CPR, and it's an ongoing discussion. It's not a one-time discussion and decision. It may change as your condition evolves. Palliative care at home. So Heather's family physician goes ahead and applies for palliative care benefits for her. Her medication for her pain, nausea, and her bowel care are covered under the benefits, and a referral is made to home health. Home health nursing visit her at home to monitor symptoms and carry out treatment as ordered by her family doctor. Based on assessment of her needs, home support was also arranged to help her with bathing. So you may be familiar with the BC Palliative Care benefits, which is available to permanent residents of BC who are facing life-threatening disease. And the BC Palliative Drug Plan includes prescription medicine prescribed for symptom control, as well as certain over-the-counter medications. And under the palliative care benefits, health authorities would also supply other medical supplies and equipment. This might include wound care supply, equipment such as mechanical lift for patients who are bedbound, a hospital bed. So this may vary with health authority. As the weeks passed, Heather is getting weaker and she's spending most of her day in bed. She's needing more help now to go to the bathroom. A hospital bed and a commode is brought to their home. Her home health nurses have started visiting more frequently. Her family doctor and home health nurse also consult the community palliative team to come see Heather to further improve her physical symptoms. Eventually, the family decides to move Heather's bed to the living room where she can easily spend time with her family and watch hockey on TV. Heather hopes she can spend as much time at home as possible. She and her care team discuss what dying at home would look like, as well as hospice care. So as the final weeks of life approach, your family doctor, home health nurses will work with you and your family to make a plan for where and how you will spend your final days. Often this would involve preparing the home so it's as comfortable as can be for you with the medical equipment that you need. Nurses will come to your home to provide care and educate your family and loved ones about the medicine that you may be using. They might start just talking to you about hospice. So at this time, I'm going to ask some of my colleagues who work in hospice and community palliative care team to share some of their experiences in helping patients plan their last days. And what are some things to consider when thinking about dying at home, as well as going to hospice? So I'm going to give this time to Joan and Dr. Eddie, Dr. Slater, and Bella, if you can maybe comment a bit and share your experience. So Dr. Eddie works at Eagle Ridge Hospital and the Tri-Cities Palliative Care team. Dr. Slater works at Crossroad Hospice, and Ms. Bella Wang is the clinical nurse specialist for palliative care in Fraser North.
I'll start first, Dr. Roper. I'm, as Dr. Roper mentioned, I work in community home health, seeing people in the community and assisting the home care nurses, the family physician, to carry out their goals if they prefer to die at home. One of the biggest factors that actually ties into whether this is possible is that you need to have a supportive two family members or two people. They don't have to be family, because dying at home requires 24/7 care. Medications are often given every 4 hours subcutaneously under the skin. Now, I know a lot of people think that the nurses come back and give these medications. Unfortunately, that service is not available to us. So the home care nurses actually teach the family how to give injections. Basically, they insert a sub-Q lock, which looks very much like an IV site, but it just goes under the skin. There's an individual site for each medication, and then the home care nurse draws up the medication in individual syringes, well labeled for the family at home. This is done under orders from the family doctor and or myself. The closer a person is getting to end of life, the more the home care nurses visit. So again, the biggest factor is having someone who can support this. It can be a very difficult time, but it can also be a very special time, whereas the family can experience special time with their loved one that they may not have been present for if the person was dying at a different site. There is a form that we do for when a patient is dying at home. Because this is an expected passing, we sign this form, and that by doing that, one of us, whoever signs the form, is certifying that this is an expected death. Therefore, when the person passes, the coroner and police do not have to be involved. At the time of someone passing, it's distressing enough, but to have a coroner or police involved, it is very, very disruptive and distress to the patient and family. The form also has an area that you fill out that your preferred funeral home, and you fax this to the funeral home, or the home care nurse will fax it for you. You do not have to prepay the funeral home, but you have to let the funeral home know that you have a loved one who is going to be passing and that you will want to deal with them. As long as they have this form and it's signed, then when a loved one passes, you're to note the time of passing and wait 1 hour. After that, you're free to phone the funeral home, who will come pick up your loved one and take them to the funeral home. They do not have to go to emergency as in the old days. This is a much smoother process, and very much appreciated by families. This process actually is 24/7, all of the year, around the clock, even on Christmas Eve, things like that, the middle of the night. So funeral homes do have a pickup service for that. I guess if this does not go well, or sometimes a family or a loved one will say, well, I would like to stay at home as long as possible, but if the burden is getting too much for my family, I would like to go to hospice. With this in mind, we ask people to pre-plan and pre-do hospice paperwork in the event that a hospice bed is needing to be transferred to rather quickly. The hospice forms basically are just signatures and phone numbers, but it is really useful to have these pre-done. By doing them, you are under no obligation to attend hospice. And if you choose to attend hospice, there are consents for each hospice. Fraser Health has over 10 hospices, and you have to sign each one that you would like to go to, or you may only wish to go to one hospice. So if you choose to go to hospice, then our home care nurses forward your paperwork to the central access, who decides who goes to what hospice throughout Fraser Health. Fraser Health has over 10 hospices with over 120 beds. So the local teams at the hospices have no say in determining who goes to what facility. Many times people think that we do, but we do not. It's done by a first come, first serve wait list process. However, a person is not put on the wait list until they are ready to go to hospice if they should be offered a bed. I'm not sure if I left anything out, but Kevin, Dr. Slater, over to you.
Thanks, Joan. Actually, you didn't leave very much out, but that's okay. I'll add a few things. So in addition to doing primarily community-based family practice, I do work at Crossroads Hospice. I co-manage patients there with another hospice physician, Helen Arnson. So hospice is a place for people who are coming to end of life who cannot be at home but don't need to be in the hospital. So it's a home-like environment for someone who cannot receive care at home. The admission criteria for hospice is generally life expectancy less than 3 to 6 months. Although our most common patient admitted to hospice may be a patient who has been at home, but the care plan is becoming more challenging just based on the physical care needs of patients. So, you know, our bread and butter patient coming into hospice is someone who is having advanced cancer, but no longer having the strength to mobilize out of bed without significant challenge, or coming to the point where toileting is becoming more difficult, for example. So our average length of stay for folks coming into hospice is about 3 weeks. Although life expectancy can be longer, and there are different reasons why the time may be right sooner or later for some patients rather than others. The team at hospice includes 24-hour nursing care. At Crossroads Hospice, we have home-cooked meals, a team that includes the hospice support staff, volunteer staff, daily physician visits, either by myself or Helen on weekdays, and also access to other providers, social workers, and spiritual care and bereavement support. So kind of a whole team to support not only patients coming into hospice, but also to support families. I mean, often it's hard work for families to care for loved ones at home. And we often see what's called a hospice honeymoon when patients come into hospice, whether from hospital or home, and just a big sigh of relief from our patients and for their families. And their condition actually sometimes improves a little bit before they start their trajectory of downward decline. I love working at hospice, and the people who work there do too. I sometimes call it my hobby job. But it's a really wonderful place to work, and a wonderful place to receive care when it's needed.
Thank you so much, Dr. Slater. Bella, I wonder if I can ask if you can comment on just how the nursing team works together to support the patient, as there are different types of nurses who may be involved, including home health nurses as well as palliative nurse clinicians.
Yes, of course, yeah. So at home, you'll be seeing home care nurses who is working closely with the patients and the families, and of course the family physicians. And then the nurse really create that, you know, three-way or multi-way communication. They are really helpful in terms of, oh, okay, maybe I can phone your GP about this, or maybe I can phone your specialist about this. And then they really help with that communication with you and the physicians. The home care nurses are generally very experienced, but when it comes to a very difficult symptom management or care planning that becomes very complex, then the specialized palliative care team, which our Dr. Eddie, who's is part of the consult team as well. And we do have specialized nurses, social workers, spiritual care pharmacists. We all work as a team to help as a consultation team to help with the home care nurses, patients, and families. So they're able to do, say, joint home visits with the home care nurses. And then kind of just looking into that complex issues. However, the home care nurses will continue to be your almost like representative or spokesperson that you can connect on a daily basis. And there are nurses working in hospice as well. I just want to quickly mention that there is a fee to the hospice care, daily fee. However, it's very similar calculated with your income, just like the long-term care. Currently, it's about $39 somewhat a day, and that includes all your medications and meals and nursing care and everything. And then if the fee is a burden for the family. There's a way that we calculate the patient's income, and then it's going to be a proportional kind of deduction if there is proven to be financial hardship. And the nurses in hospice are definitely, we often tell our patients, and especially the families, if like taking care of your, for example, mom is getting too difficult at home, then if you want to come to hospice, the nurses will be the nursing team, and then you can be the daughter again. So we often, help so from the home care nursing, they will encourage the patients and family to think about, okay, so where is gonna be your final location? Is it gonna be home? What needs to be prepared? Is it gonna be hospice? How the hospice still look like? COVID has changed a lot of things, but we used to offer hospice tours so you're able to come and look at the environment. You might still be able to do that if you talk to the home care nurses, and depending the COVID situation, you might still be able to do that. So yeah.
Thank you so much, Bella. And I think one thing that's important to remember, there's a lot of information here. You don't have to remember all of it and know all of it at this moment. What will happen is it's a step-by-step process. When you are identified either by your family doctor or your oncologist, another healthcare provider as having palliative care needs and you need more support, that referral to home health is made, and home health nurses often support you step by step, and they help provide that guidance. And those forms we mentioned, such as expected end of life at home, hospice paperwork, you don't have to go on Google and find those forms yourself online. The home health nurses will help you with those when the time comes, and have those discussions with you. So it's a step-by-step process. And I really appreciate what Bella said as well, is with that support, we hope that family can feel like family again, and not just feel like they're so overwhelmed and being burdened by becoming a care provider. And that could be so daunting as the patient's medical needs increase and is constantly changing at end of life. Does anybody else on the panel want to add anything in terms of palliative care at home and thinking about hospice, going to hospice? Okay, great, thank you. So thank you very much for sharing your experiences. And we will have more opportunity to talk about this in the Q&A as well. If anybody has any specific questions for any of our panelists. But before we close the presentation part of our talk, we have a special guest today who has kindly offered to share her experience with walking with her father in his end-of-life journey. So I want to welcome Shauna Lim. Her father died of colon cancer more than 3 years ago. And since that time, Shauna has become the proud mom of a toddler, and now a baby who I believe is just over 1 month old. So we're very thankful for Shauna for being able to take time out of her current busy schedule to share. So Shauna, thanks for coming. And I think we often say that we need to provide more support for our loved ones facing end of life, but we might not know what is the best way to do that. So I wonder if you can share a bit about the background of your father's illness, and also what it was like for you to spend time with him in those last months. What did those conversations and moments look like?
Yeah, thanks, Dr. Roper, for having myself. Hopefully my kids in the background won't be too noisy, but I'll try to keep it concise and just share a bit of my experience. And yeah, I just also wanted to just start off in terms of, in terms of our experience with Fraser Health and with the whole palliative team. It was, I think just being part of the experience, even though it was a very difficult time, but I think the team made it as smooth as possible during that time. So yeah, so I think in terms of a bit of a background, I guess, in terms of my dad's situation back then. So my dad was initially first diagnosed with colon cancer back in 2013. So at the time he went through chemotherapy, radiation, all of that. So first time around, it seemed like he was doing pretty good. And then he was actually good, was healthy, I would say from 2015 to 2017. So unfortunately, cancer came back fall of 2017. And at that time, I think it seems like, I'm not sure, this happens to everyone, but it seems like when cancer does come back a second time, it seems to be more aggressive. So yeah, so second time around, my dad had tried to do chemo all over again, but this time around was like, whoa, like it was like too much for him in a sense. He was like, you know what, at this point, like and he was a really tough man too, in terms of being able to handle like treatments, radiation. He was just like, you know, at this point, I'd rather die than to go through chemo. And for me, it was actually quite heartbreaking to hear. We're just like, oh man, like, are we just not even gonna do any option? Are we just gonna just let it be? So I guess at that point, it was just like, okay, so it was a very gradual, what's the word? Gradual process in terms of him losing his mobility, I guess, in a sense. And yeah, so I think it was just, and from there, and actually my dad was on painkillers like Advil and like Tylenol for like the longest time. And truthfully, I wish we had known that this presentation that we just went through with Dr. Roper, I wish we had known all this information prior to then, in terms of every question we had was basically answered in this presentation. And I'm thankful for, you know, the medical team in terms of answering these questions we had to, you know, in terms of like, you know, like hydromorphone, like these kind of like pills, like I wish we had known about it earlier, because, you know, my dad was concerned about like addiction and stuff like that. And my dad was in so much pain, like Advil and Tylenol, double strength or whatever, did absolutely like nothing. You know, I think he was in so much pain. And after managing that pain like much better, was like, oh, okay, we can kind of breathe a little bit. So yeah, so and I think in terms of our connection with, I think, palliative care, it was spring of 2018, around Easter, around that time. So I think my dad was hospitalized because his pain was so unbearable. We're like, okay, we need to go to the hospital. So I think it was during that time we were discussing with, actually, I think Dr. Eddie, I don't know if he remembers us, but I'm sure he goes to a lot of different patients. And one of the things that was suggested was going through palliative care. And we're like, palliative care, like my dad seems okay, like why do we need to go through palliative care? Like, and I think the term palliative also, it just seems, so when you hear it, you're like, oh, like you're dying, right? And I think part of us, that human side of us, was just kind of like, well, he's not dying yet, right? Like we don't need to go through this route. But you know what, I think in hindsight, that was actually the best decision we made for our family, in terms of like managing the pain and having the doctors and the nurses come in. And you know, I think pretty much what this presentation was about, in terms of having the best, being comfortable in your own home rather than saying like a hospital setting or somewhere else. So yeah, so I think having that pain, having that treatment at home. And I think my mom was obviously actually she was like the warrior in all of this, being my dad's primary caregiver for months, because my dad was also bedridden from, I would say, from basically Feb of that year until July, until his passing. So it was a good like half year of being bedridden, and that was extremely challenging for our family too. So yeah, so I guess my mom in that sense was kind of the so she did a lot of the caring for him. But I think having the nurses come in to be a part of that process really helped us too as a family, and in terms of guidance, and kind of what Dr. Roper was saying in terms of like, you know, not everything is like one time all this like information, because it's a lot of information. So I think it was over a gradual of weeks and months that we were kind of revisiting some of these topics too, and that really helped it kind of be like, okay, what's our next step and how do we kind of move from there? So yeah, I hope that kind of answers some of the questions, Dr. Roper.
Yeah, thank you so much, Anna. And I'm really, really glad to hear that you felt well supported by the team. I also wonder if you don't mind sharing, just, you know, sometimes people say, you know, I want to spend time with my loved one, but I don't know what to say. And it might be intimidating or awkward to sit with them. Like when you were in those moments of you're sitting with your father, can I just ask you, like, what did you guys talk about?
Truthfully, we just kind of like, I don't know, every day seemed different. And I also, a bit of a side note, I also took some time off work as well too, to also spend time with the family and so doing errands. So yeah, I think some days, you know, for me personally, we took the time to kind of talk about anything and everything. And, you know, there were days where I would just sit with my dad, it'd be just, we were on our phones doing our own thing. But at the same time, sometimes we would just sit there with no phones and my dad would be like, okay, so is there anything you want to talk about? And that was a time where there were some questions I did have actually that I never really brought up when my dad was healthy. So I think an example of this was maybe like some questions I had as like, maybe in my childhood that I would never dare to bring up with my dad, given this, sorry. Yeah, so I would never dare to have asked him during, you know, when he was healthy. So he's just like, okay, well, if there's any questions you want to bring up, ask them now, or yeah, and I think it was just taking that time to just kind of talk about it. And I think that yeah, I think a lot, talking about like my dad's childhood, or even, yeah, I guess when you're so busy with life, you don't really you don't really have the time to talk about, I don't know, the little things in life. But I think these are the little moments that just like, yeah, that happened, So just being able to spend that time for me was very important. And for me to have asked certain questions, that was like my burning questions that I had. So I was thankful I had the opportunity to do that.
Thank you. And so I think it's important to note that when you're with the dying person, you don't just have to talk to them about their health.
Mhm.
Just talk about anything, just keeping them company.
Exactly. Yeah. I don't think we talked too much about my dad's health, to be honest. Like, and I think like one of the questions in the PowerPoint was just that, how much time do we have left? And I think that was kind of in the back of our minds, was just like, truthfully, I don't think we ever knew how much time we have left. We just kind of like spend every day as is. And yeah, I think just being able to spend that time together, and not every moment has to be serious and like talk about life, and has to be like that everyday thing, right? So I think just being able to, they spend the time with them however you think is comfortable, whether they like to talk about jokes or like even like taking videos together, photos together. And for me, those are like really precious to me, that I'm able to go back and be like, wow, these are like my dad's last moments, even though it was kind of painful to look at that, because that was not the dad that I remember, like being so sick. But I think for me, it's part of my grieving process to be able to go back to that and be like, okay, like these were my last moments with him, kind of thing too. So yeah.
And can I ask you, what was the grieving process like for you, just after he died?
Yeah, I think in terms of grieving process, like truthfully, I would say it took a while. In terms of, I think especially in the first year was like pretty challenging and pretty difficult. And one of the things my dad was actually quite adamant about was actually not pulling the plug. That was the scenario, and in terms of him dying. So I always wondered what his last days would look like too. Like as I mentioned, like no one really knows when your last day is. And when he did eventually pass, it was actually, and one of the things I wondered was like, I even Googled, I'm like, how does a cancer person die eventually, right? And do they just keep sleeping? It just sounded like they would constantly be like sleeping, and then I don't know, all these different things. So in my dad's case was actually he was what was he? He was actually quite alert prior to him passing. And then all of a sudden within hours he passed. And it was, to me, was a bit like shocking in a sense. And also surprising. It was like, whoa, surprised, but not surprised at the same time, if that makes sense. It's just like, part of me was like, oh, it's a bit surprising that he passed. But at the same time, he was already so weak and his body was kind of shutting down on him. So so I think in terms of the grieving process, like, that took a while to kind of I wouldn't say get over, because I don't think you ever get over someone's death, in a sense. I would say, the first year was hard in the sense, especially I think with the holidays, Christmas, Chinese New Year, and like Easter and all of that. And one of the moments for me was actually, I think shortly after my dad passed, actually us leaving, he actually ended up passing at the hospital. So when we left the hospital, for him to not be able to come home with us, that was like a moment, was like, whoa, that was like weird, like just leaving him there and he couldn't come back with us. That was a moment for me, was like, well, that's kind of weird, like this person you've known your whole life, that who's not able to come home with you, that kind of feeling. And also as odd as it kind of felt, was also, I also checked like my dad's time, like WhatsApp timing. Like, part of me was kind of secretly hoping, okay, when was he last online? Like, would he kind of online and check his phone? I don't know. It's kind of a weird feeling. I don't know how to quite explain it in a sense. Like, it felt like he was taking like a long vacation somewhere. Maybe he'll check his phone or check my messages, or at least I felt like, could I message him somewhere? I was like, could I message him in heaven or something? He could reply me in a sense. So it's all these different things that, that goes through your mind. And like, and because my dad was on his phone quite a lot too towards the end, and he was actually quite alert, like pretty much right until he died, he was very alert. He was on his phone. So part of me was like, man, I wish I could message him and just ask how he's doing. That was kind of part of me in that sense. And so that was difficult in a sense. I'm trying to overcome that. And also when we had a family dinner shortly after my dad's passing, maybe like a few days after or a week, and then my dad would always sit in the same spot, and him not being there was like also very like, oh, no one also dares to sit at that seat too. It was kind of weird. Like, which is like, yeah, but yeah. So it's just because of that missing figurehead, I guess, in a sense, and that keeps coming up. I think even like the holidays and stuff, like this person would do this or that, or be at that spot, but they're no longer there. So I think that's part of the grieving process too. But I think, I really do think that time does heal things. I don't think it like completely, this person you've known your whole life, you love so much, and I think it hits you hard in a sense of, yeah, I think it hits you in the sense of like when it's someone else's family, it's like it's not quite the same versus this person you've known your whole life. It's just like, well, it's different. So yeah, and I think as to now that 3 years later, of course I still think about my dad. It's been 3 years since he passed, and I think so much has happened. It's been, I wish there were days, since my dad passed, it's been actually 5 grandkids that has actually joined our family. And, part of me wishes that my dad, got to know my kids as well too. But, now I, have like photos, and I get my daughters to point out, like, who's that? They'd be, oh, that's grandpa. He doesn't get to see grandpa, but what he looks like, I guess, in a sense. So yeah, so I think and with time, it does heal things in a sense, but that memory of that person lives in you in a sense as well. So yeah, so just being, yeah.
Thank you so much, Shauna, for your just really honest sharing. Appreciate it so much. I'm sure everyone online really appreciates it as well. If there was one thing, if there's anything else one thing you would like to share with someone who might be going through what you did 3 years ago, what would it be?
I'd say accepting help from people. I think that's a big one. And I think in the society today, I think we're so, where I'm okay, I don't need help with anything. And I think when you're offered help, sometimes we're quite nervous about that. So I think whether in a sense of from the medical team or from family and friends, and they're like, is there anything I can do? When people say, oh, let me know if you need something. I'm like, well, can you give me food or drop food off at my doorstep? Little things like that. I think just being able to accept help from family or from friends who support in that sense. Yeah, I think little gestures like that really goes a long way to be able to feel supported, I guess, in a sense. And people do rally around someone who's going through something like that. So just having that community, I think, is really huge as well too. And yeah, I think spending time, I think, with the person who's sick, like I said, it doesn't have to be, you don't have to talk about their illness all day, 24/7, all the time kind of thing, whether it's talking about happy memories with them and just being able to create new memories with them in a sense. Yeah, however that looks for your family or that you're comfortable with. And yeah, and I think for me, being able to, for me to have enjoyed my last days with my dad, I was glad I was given a chance to ask any questions I had, any burning questions. That to me was really big, that I was scared to ask previously, but I was glad that I didn't have to like worry after my dad passed, oh, I should have asked that, because I don't have to keep worrying about that or keep thinking about that, for the rest of my life kind of thing. So yeah, so I was glad we were able to spend that time together. And yeah, just be able to say how much, I loved him, and how much as a family we loved him as well. And in Asian culture, you don't say I love you ever. So to be able to say that was pretty big. And for him to say that was pretty special. So yeah.
Thank you so much, Shauna. Really, really appreciate that. And if I know you're really busy, if you need to go, totally understand, but if you could stick around and for the questions and answer, that'd be great in case anybody has some questions about your experience or just grieving in general. Thank you so much. Sure. So I'm going to stop screen sharing at this point. So we have some questions from the audience. I'm going to go into our Q&A segment now, and feel free to continue submitting questions via Slido, and Alana will be helping us update the questions as they come in. So the first question from the audience is, my friend told me that we should all think about our end of life and create a plan. But where do we start? What do we actually get to choose? So this is I think this is part of advanced care planning, which we didn't address fully in the presentation, but does anybody want to tackle this one? Bella, great. Please go ahead.
I can start, and then I'm sure our team members will join in because I'm sure we all have a lot to say about this. First, there are informal things and formal things that you can think about when it comes to advanced care planning. When in human life, when we're in different stages, we all have different wishes and wants, and then whatever that creates meaning in our life. So that's one thing that you can start thinking about if you have not done any planning just yet. So, am I freezing?
Yeah, you did freeze. I think we can still hear you though.
Okay. Yes.
Oh, you're unfrozen.
Okay. Sorry, sometimes it happens. So like whatever that creates meaning in your life right now, that, I remember watching a kind of a physician in the States talking about advanced care planning for her dad. And then one thing that her dad wants to be resuscitated, one reason that her father wants to be resuscitated out of any event from a surgery would be that if he can continue to eat chocolate ice cream. So that's one thing that you can start to think about. Of course, there are many things that includes your wills, your living wills, your advanced care planning, including the medical treatments that you would like to go through, you want to be resuscitated or not. There are Cindy is showing this this resource page right now that actually has a lot of information in it. So if you look at, for example, Fraser Health Advanced Care Planning, it gives you a lot of information there about what to think about. And as well as my voice, which is a BC ministry document. It's a very complicated and long document though. So you can, if you have elderly parents, for example, that's something that you can go through together and slowly. And then sometimes it's just a conversation with your family and knowing somebody who you can trust and will help you to make the decision that you want when you're not able to speak for yourself. We all trust a lot of our friends and family members in our circle, but for example, I know my mom loves me, but she might not be able to make the decision that I want. She might be making decision that what she wants when I'm not able to speak for myself. So that's one of my decision point when I appoint who I want for my medical decision making, or even just life and death type of decision. So my husband knows what I want, and I know what he wants, and we talk about it sometimes, and that's crucial conversations in the family, even if you don't have something formally down. And I wonder if any of our team members would like to contribute.
Yeah, thank you so much, Bella. I would really encourage the audience members to look at the Fraser Health Advanced Care Planning website, as well as My Voice, which is the BC Ministry of Health Advanced Care Planning Guide. I think those are really helpful to read through just to get a basic understanding. And I think your family doctor is a really good starting point too. Because what we want to emphasize in advanced care planning is that you shouldn't be feeling like you're receiving a menu and you just take off the things that you want, because some things may not be relevant to your medical condition. And it's all really, I think goals of care is so much more, advanced care planning is so much more than whether or not you want CPR, as I've said before. It's very much based on what is your unique health care circumstances. So when you go to your family doctor, they know you, they know your medical conditions, they know where you are in those various conditions. And I think they can play a really crucial part in starting that conversation and guiding you through, even what conversations you should be having at this stage. Kevin, can I pick your brain as to, when someone comes into your office and tells you that, they've been hearing a lot about goals of care, advanced care planning, they don't know too much about it. Where should we start? What are some initial things that you talk to them about?
Yeah, thanks for the question. I think often having patients check out these resources is often where I would steer them. When it comes right down to it, it's like you mentioned, not a decision about about CPR or not CPR. That's just such a small part of it. It's really more about one's values and what things are important. And we often talk about, what's more important for you, with your unique personality and illness trajectory. Is it about quality of life or is it about quantity of life? And what are the trade-offs that you're willing to make in order to preserve what's most important for you? And more important than a document where you have this recorded. It's like what Bella mentioned. It's that honest conversation with your spouse, with your adult children, with those individuals who would be speaking for you if you're not able to speak for yourself.
Mm-hmm. Thank you very much. I'm going to move on to our next question now. This audience member says, I have end-stage cancer and I'm at home. And thankfully, the doctor has prescribed some medications for the pain. I have not told anyone, but my daughter has struggled with addiction and I'm worried she may get my pills. What should I do? Go ahead. Go ahead, Dr. Eddy.
Hi. Yes, working in community health, dealing with people at home, we run into this. The nurses are very astute about assessing any risk factors in the home. Many times what we do is the person purchases a fishing tackle box or something that can be locked and put so that the other members do not know what is in the box or able to access it. But yes, it is a concern because we do see diversion and sometimes people's medicines start to disappear. And it can be due to family members using it or selling it. And as we all know, opioids are very dangerous. And we also, with regards to pets, advise that people make sure that they take good care of medications and not leave them out.
Can I just add that please talk to the home care nurses who is working with you right now, because the nurses are really good at coming up with strategies, because this problem is not unique. And also we want to also prevent, just like Dr. Eddy said, pets or sometimes kids, right? Like get into things. So talk to the home care nurses. We might be able to come up with something or even a lockbox or something. And then I do see different strategy as well. A box that doesn't look anything like a toolbox. And it has a unique lock number, only you and the nurses would know.
Yeah, those are really good tips. And
Dr. Roper, one comment about the advanced care planning. I tend to represent it to families that it is one gift that they can leave their loved ones so that the loved ones aren't struggling to guess what they would have wanted.
Yeah, I think that's a very good reason to get started and discuss with your families, just to relieve that guilt and anxiety that they may have if they're trying to guess what you would have wanted. Absolutely. Thank you so much, Joan. I'm going back to the question about diversion and pills, and I really thank this audience member for submitting this very relevant question. One thing that is pretty easy to do, and I recommend all my patients to do, is if you have any extra pills lying at home, bring them back to the pharmacy, pills that you don't need anymore. What we often see is that as your disease is changing, your doctor may prescribe a different dose, they may switch you from one opioid to another. So you might go from morphine to hydromorphone. So suddenly you have a supply of morphine at home that you don't need. Take that morphine, bring it back to your pharmacist. Your pharmacist will safely dispose of it, such that you don't have a lot of extra pills that you don't need lying at home, which poses a risk to other people getting to it, as well as confusing you as well. Because if you have a variety of pills, it might get kind of overwhelming as to which one you should be taking. And you don't want to mix them up. So always bring back unneeded extra pills back to the pharmacy. Now, this is the other question we have is, what does it feel like to die? So I think we probably none of us can comment on what does it feel like after you have died, but we can certainly talk a bit about what it feels like leading up to it. And I think as a lot of the end of life symptoms we see in the last weeks, days of life, we do see patients get often more fatigued, more tired. Sometimes they could become a bit more confused, maybe more difficulty recognizing. Not in all cases, as Shauna mentioned, her father was very alert until his last moments. They may start to eat less and less, and some patients may stop eating altogether and maybe only take sips of fluid, or only want to have their mouth wet with a cotton swab, with a sponge. And then there are certain things that we look for, which may be an indication that patients are in their last hours of life. Their breathing pattern may change. You may see a type of breathing where they will breathe more rapidly with long pauses in between. And sometimes people mistake that for shortness of breath. They feel like their family member is gasping, but that's actually just a natural change in your breathing as you're in your last hours of life. Because the patient may be less aware, they may be less able to clear the normal saliva that's in their mouth. So it might accumulate in their throat. So they can sound a bit gurgly. And we sometimes call that a wet snore, because it sounds like they're snoring, but it's a bit wet. And at that stage of life, the patient might actually be quite unaware. And I think often those of us who are around them might notice that a lot more than the patient themselves. And they're often not uncomfortable. Does anybody else want to add about what dying may feel like?
I think, Dr. Roper, one thing that's important that a lot of people don't realize is that dying is a process over a number of weeks. Usually it could be a number of months. But when people take on the idea of adamantly feeling they have to have end of life at their home, caregivers can get quite burnt out, because it can be a very long process. And we end up seeing some caregivers saying, is it ever going to end? So that leads to a huge caregiver burden. And that would be one time that would be good to consider hospice.
Thank you. And Bella?
Again, I don't have the experience, so I cannot say exactly how you or your family member, loved one, would feel like as the dying process goes. But I think it's always important to express. If it's yourself, you let people know what you want, how you feel, so that we know how to help you. And if it's your family member, you can ask, you can always ask the question, are there anything else? Are there anything that I need to know to help you? When I'm teaching the nurses, it's really interesting how although we all may die from different causes, some people are cancer, a lot of different chronic illness, but the end stage is a common pathway. So a lot of symptoms are very similar. And talk to your nurses and the physicians. They are the ones who are expert in treating those symptoms to help you feel comfortable. And remember that the symptoms are only physically, but also spiritually and emotionally. And there are lots of feelings. And we do have professionals who can help you. We have social worker, we have a spiritual care practitioner, and also you do also have your own communities. It could be a faith-based, or it can be the friends that you have worked with for a long time, your colleagues. Remember to use those resources. And then it doesn't have to be a medical event, right? So, sometimes in the hospital, we see people who are all hooked up with all kinds of tube. A dying picture can look like that. It can also be that it's in a place of your choice, and then we're trying to keep you comfortable in all aspects. Thank you.
Thank you so much, Bella. And thank you for alluding to the spiritual and faith aspects of dying, because that's actually our next question. So this audience member asks, our religion and beliefs seem to be different than the nurses and doctors we have met in the system, and they don't understand. Do you have any recommendations? My mom is worried that bad luck will come to the family at her death as a result. So I wonder if I can ask Kevin if you can answer that question, just because you do see many types of patients from many faith and cultural backgrounds experiencing end of life at hospice.
Sure, thanks, Cindy. Yeah, I think it behooves us who work in palliative care to be aware of different practices, religious practices and beliefs, especially as it relates to planning for end of life, final days, final hours. So we do have resources available. I'll speak to hospice, specifically, or even in our palliative care teams more generally, but we have spiritual care practitioners who are resources for us, nurses and doctors and others who are caring for patients. So one of our spiritual care providers can meet with the family. They can review their planning and expectations around managing those end of life times, and in hospice setting we will do our best to allow a family's practices and beliefs and rituals to be respected. So certainly we have had individuals in hospice from many faith communities with very different and unique practices. I mentioned to Cindy just when we were preparing for the talk, several times having individuals from First Nations communities who were, able to have smudging ceremonies that were part of their beliefs, and certainly those who from Buddhist and Muslim faith communities, Jewish faith communities, where there are certain very important aspects to their dying and their immediate aftercare. And we've been able to, just by being aware of those things, to plan accordingly.
Thank you, Kevin. Does anybody else on the panel have anything to add about how we as a team will try to honor and respect these different beliefs and practices?
It's hard to know exactly what the worry is from the question, but I feel like most teams would probably be open to hearing about the specific fears in this situation. So there was a worry about her mom feeling that bad luck would come. And I think sharing those worries or fears with the team might lead to an area of better understanding for the team, so that they can help this family better.
Thank you so much, Dr. Tamber. Yeah, I think that would be really important if you feel comfortable, is to talk to the care team, talk to the nurses about what you might be concerned about and maybe what you would like to see done differently. Bella, I don't know if you're froze a little bit. I don't know if you can still hear me. Can you hear us? Oh, great, you're back. Yeah, I was wondering if you can comment on some of the any training that the palliative care nurses or home health nurses might receive about just understanding cultural competency.
Yes, it's actually mandatory for everyone in healthcare now to take the cultural safety and competency course. And then, but however, those are the theories, and then really it's teaching all the healthcare workers to honor and respect. One thing that makes this world beautiful is that we're all different, right? We're all from different places. We all have different backgrounds. But there is no way that we can memorize all kinds of rituals and cultures and religions. And we can't memorize that. So please tell us, and then we would love to honor and respect, and then try our very best. For example, in a hospice setting, we always try our best to have different ceremonies, have different, just we go over above and beyond to try to honor that culture or that spiritual or that religious or whatever that creates meaning, and that's so important for you and your family. So please tell us, then we'll try our best. Because if you don't say, then we wouldn't know. And then we don't want to have the wrong assumption. The worst thing is that we assume the wrong thing, right? So that's the best gift you can give us, is to let us know what's important for you at the end of life.
Thank you, Bella. I think it's very important to be aware as well that we have this research of the spiritual care provider, and maybe not everybody is aware of that. And they're and they are really the experts in the different types of many different types of faiths and practices. And I think they would be a really good resource to tap into. You can relate to them more. So yes, but definitely bring this up with your team. So the next question is regarding patients who may have unstable housing. So if someone is unhoused or precariously housed, how do you deliver palliative care to these people? So Bella, I think it sounds like you've had some experiences before with patients in this situation, if you don't mind sharing.
I'll try my best because I'm not too sure if I have seen a lot of them, but definitely the population often, because of the characteristic, because there's no housing, or they may go from one friend's home to another relative's home. It definitely make the care itself a little bit more challenging. However, at the same time, I feel that it's really respecting a person, our patients, freedom and their lifestyle and their choices. So as home care nurses, if there are ways to provide some visits or have somebody coming to the clinic, and when time comes, when the hospices definitely can be a choice, but the most important thing I feel is really knowing that person's goals of care and the wishes, and how to balance, because end of life can be difficult already for for patients who have lots of friends and families, have a home, to even have a home that it can be difficult already. And then I think with the less resources, we have to come up with creative ways and how we can provide, like even providing equipment can be a little bit challenging without a place to go, right? So however, if the person is willing to, we're more than happy to kind of have that communication and then see where is the best place. Like our home care nurses can go to, say, some of those shelters or modular houses that to provide some care, but then again, it's really respecting that person's goals and what the person wants.
Thank you, Bella. So Carter, Lana, I'm just looking at the Slido questions. Are there any more questions have come in the last little bit?
Yes, there are. I've just added them to our Google Doc.
Okay, let me just refresh it. Okay, let me just see here.
You see the second question there?
So the question I see here is, my greatest fear is hearing that I need palliative care, and being 78, I suspect it is time to consider that the day may come. So this isn't a question, more of a statement. And I think what I hear is just kind of this fear about death coming one day. And maybe the question is, how can we mitigate this fear in some way? Does anybody have any thoughts about that?
Yeah, it's Anu. We've been talking a lot about dying in our conversation about palliative care, which is obviously fair. But I think a lot of us actually think about palliative care as a way to live well for the time that you have. So as much as we're talking about dying, when you're seeing a palliative care specialist, you're really talking about living and how do you want to live now, given what's going on with your health. So I don't know if that allays that fear, but I think all of us on this Zoom chat would agree that most of our conversations with patients are not about dying. fair about living and what's important to you today, tomorrow, next week, and how can we make that happen?
Mm-hmm. That's a really important point. Yeah, it's just how do we make the best of what we have and maximize the time that we have with our loved ones, for sure. And I think some of the things that were discussed earlier about having those discussions with your family, doctor, your family, planning ahead. I think when you feel a bit more prepared, that might mitigate some of the fears and anxiety as well. Thank you, Alana, for the questions coming through. So I think we still have, Cardi, do we still have a little bit more time to go through more questions?
Yeah, we've got about 5 minutes here.
Okay. So one of the questions is quite specific. It's why do you need to wait 1 hour after the time of death before calling the funeral home? So I might let Dr. Eddy answer that one.
You wait 1 hour. It's because there is no professional coming to certify that the person has passed. The 1 hour allows time to pass so that you can be certain they have passed. It's just an arbitrary number that was assigned. And most people, the consensus was that 1 hour would be appropriate.
And I know it's important to emphasize that you don't have to call the funeral home right on the hour, that
No.
you could just spend time with them and call when you're ready.
Mm-hmm. We've had some people wait many hours and others call right on the dot. It's really how comfortable the family feel with having their loved one in the home after passing.
I just want to add that you don't have to have the form to be able to die at home. It's really help you to, for example, if your loved one dies in the middle of the night, you don't have to wait until the morning, or sometimes it could be a weekend. You have to find a home care nurse or a physician to come in and to pronounce that your loved one has really passed. So, so this form really helps to kind of smooth things out a little bit, especially with some culture or some spiritual belief. Maybe they want to, really speed up that process to get the person to funeral home and have the funeral within, say, 24 hours or something like that. Then this form will really kind of buy some time.
Thank you, Joan and Bella. The next question is, how do you refer to hospice or to palliative care? Is there a centralized system? So I might ask you again, Bella, because I think it might be the best person to answer this system questions, since you do a lot of work with the system and the flow of patients.
Not a problem. So, so the most important thing is to talk to your family physician or the physician you're working with. So that would be your very first step, because when you think that you are palliative, there must be some signs that, maybe did the physician talk to you about your being palliative? Are there things that you need help with? So talk to your physician. And, in general, if you need help, physical help, you could always phone this home health service line. Cindy, I don't know if you're able to, do you have a slide for that, or do you have?
For a home health?
A home health service line, yes.
Yeah, I can just pull it up. So Fraser Health Home Health Service Line. Yes,
so that's one number that you can call to make a referral for yourself, for your family members, for your neighbors, if you feel that that person is palliative and needing a little bit more help. Okay? But I think your best bet would be still talking to your physician first, and go from there.
So let me just see, Bella. This is the website.
Yes.
So this is the learn how to access home and community services. Contact us. New clients,
Yes.
contact our home health service line 1855. And
Yes.
so I think often in the community, home health is the starting point for accessing palliative care services. And yeah, I think whether you're calling home health or going through your family doctor as well, that's a good way to go. And I know sometimes that referral to home health might actually be initiated with your oncologist as well. So it could be coming from different points, but often I would say home health is probably one of the most central locations. So I think we're out of time, actually, unfortunately. So I wasn't able to get through all of the questions, and I think some of them, there's some more questions about advanced care planning as well as medical assistance in dying, which is certainly relevant to end of life, but we're fortunately not able to cover today, but they could be topics for future discussions. So thank you everybody for your time. Thank you so much for everyone on our panel for sharing your expertise. And thank you to the division for giving us the opportunity to have this event.
Thank you. I just want to say thank you again to Dr. Roper for the presentation and the panel for putting their minds together to answer the group's questions tonight. And a big thank you to everyone for attending this session. So what we're going to be doing is we're going to be putting a link to tonight's event survey in the Zoom chat. I'll also be sending out an email to everyone who provided their address with a survey link and an overview of some of the resources chatted about tonight. We really appreciate it if you would take a couple moments of your time to complete this survey. It just allows us to understand what was successful, what could be worked on, and any suggestions you may have for future sessions. If you have any other questions about tonight's presentation, feel free to send me an email. I've provided it below in the Zoom chat. And if you have any other questions, I'll make sure those get answered or passed on to the correct resource that can do so. So I hope that everyone has a great rest of their evening, and thanks for joining.
Thank you.